All righty, and we are live, everyone. This is Professor Jennifer Harrison-Hauer, Exam 1 review. We're going to just go ahead and get right into it. Please ask questions. Of course, this is not all inclusive. You want to continue to do your due diligence as far as reviewing all of the stuff. Okay, so let's get started, everyone. All righty, so let's delve right into community. What is community? What does community health, public health do? What is it? The primary goal of community health, and they're exchangeable, the words you may hear, community health or public health, is the prevention of disease and disability. Prevention. So that's where we want to live. That's our comfort area. That's what we love. Disability, if someone were to have a condition, then we want to prevent complications. So it's prevention of disease and disability. Go ahead and if Thomas, if you can go ahead and just type in your instructor or what have you, I appreciate that. Welcome. And so the prevention of disease and disability is achieved by, again, we want to promote those conditions in which people live the best possible life that they can. It is a specialized nursing area as far as public health, community health nursing, where the public health nurse works autonomously. That means she's independent. She has those skill sets in place to where she is an independent provider, and she has autonomy. So that's important for you to keep in mind. Where she works is, he or she works is in the community. So she's not in a hospital setting. Her population is, her patient assignment is the community wherever she serves, whether it's at schools or church or a certain area of town. Everyone that's involved in that area, that community, is who she's targeting. So then she's helping the underserved. She's helping the underserved with problems and helping them with solutions for that defined area. She's looking at so many things. She wants to know the gender, the age, the race distribution. She's looking at subpopulations as well. She's looking at things that could potentially put those individuals at increased risk for illness and disability and premature death. Okay, so she's wanting to know as much as she can about her community, so she can help them to live the best possible life that they can. So the clinical practice, the focus, if you will, is not on individuals. So that's an important concept to consider, because probably before now, this may be your first exposure to community health or public health nursing and what that is. We're all familiar with med-surg, patient in room number 101 or what have you, but this is a mindset where you want to think of that your patient is the population, is the community, however is defined wherever you work. So, earlier in class, we talked about school health nurses. And so that's her population, everyone in that school, the children, the administrator, the janitor, the lady in the kitchen, all of those folks. All of those folks are underneath her realm, if you will. So then public health policies are really important because, policies in place helps us get things done. So and I worked as a public health nurse on the reservation here in Arizona. And so we would write policies in conjunction with the community, hearing their input to help move things along as far as getting certain screenings done and having things and standards in place so we can carry out our mission, if you will. So, for example, public health policies, again, we're creating standards and putting them in place. So one of the things I remember that we did was in conjunction and working with the school board is offer STD screenings and starting in middle schools, in the middle school setting. So these are definitely because we saw an increase of rates and our younger teens. And so these were policies and standards that we put in place. So that's also what we're doing as well. Let's see, they're seeing an increase in the number of older adults. An increasing population has created a challenge for public health because our population is getting older. Before, in the early turn of the century, it was infectious diseases that was taking people out, communities out, Spanish flu, this, that, and the other. But now it's these chronic conditions that are, they're keeping everyone busy, and public health, community health nurses as well. So therefore, you want to keep in mind when you're going into your community public health, again, you're focusing on everyone in your community. So your efforts should be focused on the group, that one entity, opposed to that person. We'll get into it. We're just getting started. So just keep that in mind. Health disparities, we'll talk about that a little bit deeper there, but the largest impact of health disparities is the differences in economics between groups. And we'll delve into that a little bit more. It's creating higher chronic diseases and vulnerable populations. So getting into a little bit deeper about what that looks like for someone that's involved in a community nursing on a day-to-day basis. So a public health nurse, the primary focus is, again, is on the healthcare of her communities. It's not individuals. It's not in the hospitals. It is on the community. And I know I keep repeating that, but when you go into your exam, if you put on that mindset that you're trying to do the best amount of good for your group of people that you're taking care of, I think you'll do very, very well. We're trying to prevent disease. And there's different prevention levels we'll talk about, but the goal is to prevent disease. We want to preserve people's health, promote wellness, restore to the best possible living they can. If a chronic condition exists, want to protect the health of the community. That's why you saw with COVID, different policies coming out, different things coming out. However, folks took that, and I don't want this to turn any kind of political or whatever. That was the goal, was to promote the health of the population, prevent disease, protection, and preserve. That's what community public health is all about. They do work with chronic conditions. I suppose that's, you will, if you work as a community health nurse, you will work with chronic conditions. It's not like we don't, but the focus is, again, whatever actions you're doing, you're really keeping that community in mind. I remember, again, when I was a public health nurse on the reservation, if I were to go out, when I would go out to a home of a patient that had, I think I talked about it earlier, let's even say rocket mind spotted fever. And I'm in the house and I'm talking to mom and I'm talking to family. I'm doing all of these things as well. I am also surveying the home. I'm looking at the environment. I'm asking mom, do we need to help you get things situated for your kids so we can get them in for shots? I'm helping to make sure that they everyone in that home is taken care of from a public health standpoint while I'm there. So again, you want to keep that in mind. And I see you guys taking notes, which is great, which is wonderful. All of our professors should be giving you the links and we all are. So as soon as I'm done with this, I'll have my a channel for my class, but I will convert it to a YouTube link. I send it out to all the instructors, Price, Lundy, everybody, what have you. So you should get this. So how this is carried out as far as the community health nurse is concerned, the action that's involved is the intervention focused is either in the area of primary or secondary or tertiary. And I'll spend a little bit more time honing that out. But interventions is as I mentioned earlier in class, it's an action, it's a verb. So that when you see this on exams, you should think action oriented and what is it doing for? And I'll go into that, but you'll hear primary, secondary, tertiary throughout the semester. And if you come in with a solid understanding of what this looks like, it will never trip you up. And that's what you want. Whatever scenario you'll see in an exam or what have you, and they're asking you, is this primary, is this secondary, is this tertiary? If you know what it looks like, no matter what type of setup it is or a scenario, you'll get it. So this is an example of a visiting nurse. She's demonstrating how to use the syringe for a group, probably a group of diabetics in her community in Philadelphia. I don't know, but it's circa 1950. Yeah. We've been around a long time. So then now let me work this for you guys a little bit here. So in a perfect world, we want to live in primary and secondary. That's where anyone in public health, whether a public health nurse or whatever they do, we want to stop it at, in a perfect world, we want to stop it at primary. If primary fails, and then we move into secondary, and then we move into tertiary, and then we could go from there. So let me work this. When you think primary, think prevent. So prevention looks, there isn't a disease. So whatever intervention you're doing doesn't have a disease involved with it. You're trying to prevent it. So that's why you get a flu shot when you don't have the flu. You may do an education to a group of kindergartners how to wash their hands using the row your boat gently down the stream. Now, we're not done with the song. You're supposed to still be washing your hands. Mary, Mary, Mary. Song's not over, because you're teaching them to wash their hands to prevent germs and all of that. That literally is a perfect example of primary prevention. Educate, prevention, immunizations, prevent, prevent, prevent. So that means if you see something on an exam and there's not a disease, they're doing something to prevent something. They have a group of seniors together and they want to talk to them about the benefits of eating calcium foods, because as you get older, your bones get weak or something. But no one has a disease. We're educating. Or when I would go out to the high schools, middle schools, unfortunately now, and do an STD presentation, but nobody has anything. I don't know if anybody has anything, because I'm not dealing on that level with someone that has a disease. I'm just educating and talking to y'all, okay? Or I showed a video in my class with school nurses, and I what they did, and I said, give me an example of what was primary, what was secondary, and what was tertiary. So primary is where she went into the class, she talked to a group of girls in middle school and talked to them how to like check their breast or what have you, and that sort of thing. I don't know if somebody has breast cancer. I've never seen an 11-year-old with breast cancer, but we're educating. So that's that. Now, secondary, I mentioned in my class earlier, think of 3 S's. Secondary is surveillance, screenings, surveys. I'll keep it simple like that. The focus, the reason why, the intent when you recommend someone have a screening for breast cancer or screening or depression screening, you go to the doctor's office and they ask you all these questions. In the past week, have you felt hopeless and all this other stuff? It's early detection. They don't know you're asymptomatic. That's what preclinical means. No one knows that you have depression until we do that PHQ-9, you score high, but the action that that nurse did was secondary. Keep your life real simple. Don't get into who shot Johnny and well, they have depression. No, I'm talking about what you are doing as a nurse. Okay, so these prevention things are action oriented. And then you move into tertiary. So primary fails, fail, secondary fails, and then tertiary probably would be the easiest for everyone to understand off the jump, because we are all thinking med surg. We're familiar with med surg in the world, I guess, if that's what's, public health probably didn't become fancy until COVID. So tertiary, if you want to, I don't want to say work backwards, but if that helps you, so that when you see a scenario, you can start eliminating, it's not this, it's not this, it's not this. Tertiary means a disease exists. And so whatever you do after the fact is tertiary. Everybody follow me on that? So you can say treat, that's good too. You may not actually be the person that's treating, but you may be giving them the insulin, telling them how to do this, that, or the other. But if a disease exists, whatever you do, if you give, so for diabetes, let's say for diabetes, you teach someone how to check their blood sugar. You are always, as a nurse, I hope, and I've been in this, next year will be 30 years, I hope you never stop teaching and educating when you're giving your pills and you're giving that. So when you guys are in clinical, everyone in there is tertiary, because we haven't primaried them, we haven't prevented anything. That's why they're in the hospital. They're not in the hospital to watch a presentation on the food guide permit. They're in the hospital because they have a condition. And usually, again, I want to keep this real basic. Usually with tertiary is like a chronic condition, but again, we're not talking about UTIs, but the point of the matter is everyone is familiar with tertiary because it's a disease. So on an exam, if you see anything about a condition, 99.999% of the time, now it's tertiary because it is intervention or action after the fact. I'm not looking for something. I already know you have depression. I already know you have alcoholism. I already know you have a drug addiction. I already know you have asthma. I already know you have lupus. So I can still give a person with lupus a flu shot, but they already have it. So anything you do after the fact. So if that helps you, so you can eliminate, let's say secondary is kind of like, that's fine as well. But just know that at tertiary, this is the point we want people to keep they're diabetic, to keep their toes and their kidneys and their eye sockets and all of that. But whatever you do as a community health nurse is tertiary. You cannot prevent anything from happening. It's already happened. All right. I think I beat that horse down to the ground. All right. Oh, I don't know. Oh, okay. So then healthcare of communities, everything, the actions, I'm talking about things that are being done by that community health nurse. She works primarily with members of the community. So she's working with her people. She's not going in there, I think you should do this, I think you should that. You guys need this, you guys need that. So the actions are, everything she does is focused on, again, how to make her community as healthy as possible, working with the community, all right, to carry out these interventions. she needs to do a head to toe. So her head to toe is not Mr. Smith in 101. Her head to toe is the community. So we'll talk about later in throughout our 12 weeks together. They'll talk about, your instructors will talk about the actual community assessment, but this is just getting you an introduction. So in order for her to even begin to understand what to do, she needs to do her homework. She needs to, and there's many things that she's going to do. Again, they'll get more fine-tuned with you guys in weeks to come, but just know this is basic. She wants to do a head to toe on her community, so she knows before going in. Just like I don't know, when I used to do teach clinicals, you want to read the chart first, right? Before you go in the room, or you just don't go in the room. You need to know what they have. You need to research, you need to look at their meds, you need to do your homework. So she does her head to toe, okay? And then again, whatever, there's a lot of things that go on, but whatever interventions she feels that can help her community, she's asking those community leaders, what should be chosen? What should we focus on? There's obviously many different things, but again, she does her head to toe. She designs interventions and programs. She's using data from different sources, health department, websites, any information she can find to begin to design things. So she's beginning to design her care plan, if you will, of her community. But just know she has to be focused. She needs to do her head to toe assessment of the community. It's all about it. It's all about improving the health. You want to leave the community better than how you found them. Just like when you're in clinic, you want to leave at the beginning of the shift. If they're a 10 in pain, they should not be a 10 in pain by the time we leave. A doctor should have been called, all of this stuff there. Partnership with the community, just like you partnership with your patient. You listen to what they have to say. You just don't go in and just start moving covers and stuff like that. So then keep that in mind. This slide is a little bit busy. I'm going to touch on it in a couple of different spots throughout the lecture. So health disparities in vulnerable populations are two important key words to realize when you're doing anything with community public health, because a health disparity is a difference, okay, that adversely affects or disproportionately affects different populations when you compare. Let's just say you look at infant mortality rates with Black women and infant mortality rates with white women. So and if there's a disparity that exists. And so oftentimes in public health, disparities exist. Usually, again, that's what the slide says, largest impact or how it's impacted is viewed through the economics perspective, income, chronic disease, less follow-up with vulnerable populations because of different factors. But just know that health disparities in vulnerable populations, they tend to go hand in hand. If you have someone, and we'll go into vulnerable populations, listed here are the 7 determinants of health, but I'm going to go into it a little bit more detail in a bit. But know that these 7 factors tend to exist in those that are vulnerable and or health disparities. So then again, all populations with health disparities are usually socially disadvantaged in some way. Access to care, health insurance, different things that are impacting him. And that's what these 7 touch on, but I'm going to go into it a little bit deeper as well. So you'll have these slides, like I said. So then looking at what a vulnerable population is, what makes somebody vulnerable. Excuse me, let me just take a swig. Whenever I like to give an example of vulnerable population, something that's everybody is, should agree with. It's like babies are vulnerable. They rely on someone to take care of them. An elderly person could be a vulnerable person. But so if you want to think of that little sweet little baby infant in the crib as being vulnerable, relying on someone for their every need, so susceptible to harm and harm, and I just kind of broke that out so that you can realize that vulnerable is not always clear cut. You may not think someone is vulnerable, but they are. So susceptible to harm is relative or incapable of protecting their own needs, or they can be vulnerable because of socially, physically where they live, emotionally, economic, legal. And then your goal as a public health nurse or community health nurse, period, is to reduce harm reduction. If they're vulnerable, what can you do to reduce their vulnerability or harm if you want to? So then let's see here. Hang on one second, guys. Okay, income. All right. Let me see where I'm. Okay. So again, if you're looking at two different examples where living conditions, homelessness. So a vulnerable population is a subgroup. So it's a subgroup of the population is likely to develop health problems, because that's why we're even talking about this, because we're looking at what can affect someone's health or living a healthy life as much as they possibly can. If they're vulnerable, then that's top on our radar as a community health nurse. Are they exposed to different things that we can help reduce the risk for? Homeless folks, getting them into shelters, health care. Are they at risk environmentally? For example, lead paint in homes that you don't really see anymore. It's not just your clear-cut child or an elderly person. You can be vulnerable on multiple different levels. You can be vulnerable on one level. And if you lose your job and you're out in the street, you don't have a home, you're vulnerable. Social hazards, crime, violence, diet, exercise, personal behaviors can make us vulnerable. Those with, I don't want to say certain chronic conditions, but illnesses can make us vulnerable as well, biological or genetic makeup. There are different things that I'll go into a little bit deeper that can make someone vulnerable. These social determinants of health, what you saw on the other slide, all that is that there are 7 factors, and it was listed previously, but I'm just going to kind of hone it in. Factors, when you think of factors that can influence someone's health outcome to make them vulnerable or not. So for example, if you're a high income person, you have a master's degree, you live in a good neighborhood, you have support, you have friends, you have church, nothing wrong with your genetics at all, you're like perfect, you have access, you have the best insurance in the world, your genetics is on fleek, then all 7 factors you can check off. You can have vulnerability in any of these areas here. Some are within someone's control and someone's not in someone's control. They may not be able to get out of a war-infested country or what have you, and they're vulnerable. So these factors, like number 1, like income and social status, are associated with better health, meaning if you have higher income and higher social status, they say, the World Health Organization, that you're a better health. Okay, so therefore, if you're, and I don't know the certain income, I don't think you need to be that nitpicky. Just know that income and social status can positively or negatively impact your health if you're able to pay for insurance because you have money. Education, low income, they say, is linked with poor health, more stress, and lower confidence. Therefore, as a community health nurse, if your community, when you do your assessment and you look at the census data or what have you, and they ask you all these questions, and the majority of the folks in your community didn't finish elementary school, that is going to make that community as a whole, remember, you're not thinking of that one person, vulnerable, okay? That can affect their health, all right? Physical environment, do they have safe water, clean air, healthy workplaces, safe homes, communities and roads, are good employment available, working conditions, all of these things, the physical environment, again, that can place someone vulnerable, that can affect their health if they do not live in a safe neighborhood where there's gunshots and shooting everywhere and the roads, and they can't get in and out because it floods at night or what have you. Do they have social support? Do they have family? Do they have friends? Do they have people that can listen to them when they don't get good news at the doctor's office or good news at the doctor's office? Do they have a community, their own support system? Having a lack of a support system can negatively impact your health. How many times have I talked to patients? I have no one to talk to. My mom's out of state. I don't talk to my brother. I don't know where my dad is. That sort of, I don't want to say that sort of thing exactly, but you guys understand what I'm saying. And then genetics. Genetics. Do you have a risk for this? And I had one patient that three of her aunts had breast cancer. They survived, but knowing your genetics, things that you do not have control of it, but you want to be aware, okay? Health services, where's the nearest hospital? Where is the nearest clinic? Do you have access to it? If it's around the corner from you, but you don't have health insurance, that can impact your health. And then they say men and women suffer from different types of diseases at different stages. Different things affect different genders. So that's just again, just things to know. And so therefore, these are things that you want to know about your population. And it seems like it's a lot, but most of this information is easy to find if you become a public health nurse or what have you. But these are things that you want to know as much as possible going in. So then we'll kind of switch a little bit about the Healthy People 2030. Healthy people is that we want everyone to be healthy and prosper. We want to promote good health, prevent disease. It's all about attaining healthy, thriving lives, free from preventable diseases. People wear their seatbelts. We reduce disabilities and injuries and premature death. We want to eliminate health disparities, achieve health equity. We want folks to health literacy, where they're able to understand what has been given to them by their doctor. So therefore they can ask questions because they know what's going on. That's another thing you can advocate for when you're with your patients. I have gone to several when I was a public health nurse to their doctor's appointment and been their advocate. But anyway, so that's an intro. It's not all inclusive. Healthy People 2030 is a lot, but that's the important for you guys to know from beginning, I suppose. And then let me just move this out of the way so that I can see what's changed. And I think that was one of the things on your concepts review. One of the things that's changed is to increase health equity. So that's really big for Healthy People 2030. They're really, really, really working on making health equitable to all, regardless of race, gender, creed, sexual orientation, and all of that. And then, so again, they want to set national goals and objectives to measure. I think that's a typo. Measurable goals. So that's what's changed. That's important to know. And so these goals, again, we mentioned in the previous slide for you as well. But that's what's changed. They really are focusing on that health equity and social determinants of health. So I would know that. And then switching again, you will find that when you guys start your nursing career, I mean, we do a lot of things, but one of the things we do well as nurses is we should do well as nurses is advocate for our folks. Advocate, you are the advocate for your patient. Unless they're declared incompetent, they should be able to have the right to do, self-determination, managing their own life. You can give them the information. However they decide to proceed is completely up to them. So they have a right to make their decisions. You want to review ethical issues related to abuse and screening. Certain things you have to report, child abuse and what have you. Managing chronic conditions, preventing complications, delaying deterioration, decline, and achieving the highest possible, I've said that probably to nauseam, highest possible quality of life before dying with comfort, peace, and dignity. Okay. But again, it is their decision. You can have the best laid out prevention program. I think it's wonderful, should have won some Academy Awards. That's why you want to work together with your community, because they have rights as well. So a little bit about some Medicaid versus Medicare. Medicare, I think of caring. I have to do little things that helps my mind. Caring for, I'm just looking at the chat real quick. Caring for 65, those that are 65 and older. We are seeing a rise in our baby boomers. And so therefore, they're going to keep us busy as nurses. The population of baby boomers is growing. So then keep that in mind. Where your Medicaid helps those with low income levels and classified as unable to work or disabled. And then the American healthcare system is broken down into two, broad systems, systems, I'm redundant. Private, so think of Blue Cross, Blue Shield, Aetna, you're paying into this. Well, I guess we're all paying. And then your public, which is your Medicare and your Medicaid. So keep that in mind. And let's see. Affordable Care Act, unless you've been under a rock for the past, 10 plus years, Affordable Care Act was passed to help, access to health care. That's one of the main primary goals, more people health care so they can get the treatment that they need without having to worry about the financial end too much. Increasing Americans who can afford health care, increases quality and lower costs. And then, it just says a little bit about how does U.S. healthcare compare to other places in the world. And that itself is a lecture for another day. But again, we are trying. If you've ever been overseas, living in other countries, it's different. But again, let's just focus on the slides here. We're trying the best we can in the United States, but other countries, they do real good. So then acts to help with public health. So FMLA, Family Medical Leave Act, most of us may have used it or heard of. I think is one of the best things in the world since sliced bread. I remember when it was passed in 1993. Provides job protection. You cannot lose your job. Continuous health benefits where applicable for eligible employees. They can take extended time. But back before all of this, it was 6 weeks after you have a baby, back to work. Now you can take weeks, months off and be guaranteed to have your job. This Leave Act made advancements in ability for folks to care for their families if they needed more time and not have to worry about losing their jobs. Okay, so that's what FMLA is in a nutshell, really. Then you have the American Disability Act, which should be self-explanatory. QSEN, Quality and Safety Education for Nurses. It is not federally moderated. Yeah, that's what that says. it's to help improve what we're doing. I think of it as a quality check, quality improvement, evidence-based. I would know these to memory, would be good. Helps with quality improvement so that then folks are looking at ways that we can always improve the care we provide as nurses. Evidence-based, gotta love my evidence-based. Computer and IT, again, always looking for ways that we can improve the quality and education for nurses. So it's for, for us to be better nurses and safety. So just, I would just kind of memorize those. So then evidence-based practice, it's a hotly debated topic, but how I like to see it is that anytime you're involved in the lives of others, you want to use the best possible data that's out there. And so, because someone's life could very well depend on it. So you want the current evidence, not something from 1902. Even if it's evidence-based, it's old. And making decisions about the care of your community, individuals, everybody. That's why we ask you guys when you do your work within 5 years, scholarly sites, none of that wiki stuff. And so this pyramid here, it's the hierarchy of evidence. And I'm not going to get to each one and really into detail specifically. It's in your text, but just know hierarchy of evidence where you want your systemic reviews and your randomized controlled trials when they have like double-blinded or what have you studies. That's what you want. Those are the two. They're all in, you can use any of them, but most folks really, besides systemic reviews, randomized controlled studies, they pretty much live in those realms. You can do case controls, you can do cohorts, but the best is the cream of the top. And then if if you're looking for folks to take your information seriously, you want to pull from systemic reviews and randomized controls studies. So they're in order of decreasing importance and use. I don't think I've ever seen an anecdotal. I mean, there's expert opinions. I'm an expert in women's health. I'm a women's health nurse practitioner, but I would not want to pull for somebody's opinion when I have systemic reviews available. I mean, like put it in writing, have it evidence-based and test it out, not just somebody's quotations. The double-blinded randomized control trials, that's also like top of the list where no one knows, even the investigators, who's getting the placebo and who's getting this, that, and the other. So that's what you want. That's your clinical trials, is your randomized control trials there. And then moving into the family, how the family has evolved from, it continues to evolve. And so as a nurse that's working in community, your idea of a family may be different than what others feel. And it's perfectly okay to have whatever family that community wants, none of your business. Understand that family structures have changed over time, and it may continue to change. There is no right model of the family. Each family is beautiful, wonderful, unique in their own special way. So then keep that in mind when you're going out, not only when you see families that may look different from your own. There may have some unhealthy habits. That's why you're there. Maybe it's a little bit of dysfunction going on. Can help them out, get everybody into counseling or group therapy or offering suggestions. But again, that the family structure has changed and evolved. And so when you go out in the community, Be aware of that and just roll with it. Family development, looking into assessment. When you, again, this is your community. So when you go out to a specific home, you want to do your, before you even go out, you want to plan. You want to plan, organize your visit before you go out there. Assessment of family requires an organized, you want to organize plan, including who, what, where, when, why, how. Who are you seeing? What's going on? When have you need to arrange for when it works best for the family? Where are you going to meet them? Hopefully in their homes, but they may not want you to come to their home. They may say, meet me at the church or meet me at the park. Why are you going out there? What does your referral say, or what's the reason for your visit? And how are you going to carry that out? Purpose of seeing the family, which family members are going to be present? What are you assessing and why? It could be a child find, it could be an elder check, welfare check. How will you obtain the necessary data? Get as much as information beforehand. When I used to go in as a public health nurse, I literally had like a little, one of those little small notepads, and I just keep it in my pocket. I would just go in looking just like this. I wouldn't have a stethoscope around me. Not initially, I would just go in and just talk to people. Go out when it's preferred for folks. Some people are not morning. You got to work out all of that with them. And so you have to be extremely flexible. It's all about what works in most, when most of the family is available. If daughter is taking care of grandma, she's the main person. She knows all about grandma's history, but she doesn't get home until 5:02, then you're going to go out there at 5:30 and just work it out with your boss. It is more informative to view the family as a whole, get everybody and get together so you can watch the sparks and the dynamics. You can get a lot of information by observing and let people talk. They'll just run off. You just pick up all the information you need and just smile and nod and ask questions. So for example, what do I want to tell you guys? If you notice such things as when you have let's say you have a group, you're a family together, 5 people, I don't know. And you know, so one person is talking, you're asking someone else questions, and they won't let that person talk, or they answer for them. They're not letting them communicate, like limited communication, or certain people are dominating the conversation, can be suggestive of problems within the family. I would know that. And it's a red flag. So those are things that you need to keep an eye out as well. Evidence of healthy families can be seen in a variety of ways. Not everybody's unhealthy and dysfunctional. But again, when you're seeing things that are red flags, such as limited communication, if one person is saying everything, even though you're asking someone else a question, they won't let them answer. These are things to be mindful of. Open communication. So what does, I don't know, healthy can look like, or any relationship, when there's open communication and dialogue among everybody. If I ask the little boy a question that's 8, I don't need you to answer for him. I need you, he can talk, so I need to hear from him. I need eye contact. Those are things to be aware of. So you want to see open communication when everybody's talking, mutual interactions, balance, lively, expressions are good, all of that sort of thing. So you're going to watch nonverbal cues, but definitely if there's limited communication or someone's dominating the conversation, this is something that's a red flag, and this is something I would remember as well. And then, so what does a family in crisis look like? Well, I think we all could probably have an idea. So when you're thinking of, if you were to see something talk about family crisis, any type of crisis, emergency or what have you, just think that for some reason, again, you're thinking of the family, they're not able to cope. They've lost their ability to cope with whatever is going on with an event. Something has triggered them. You might think, you've had friends, well, I don't know, maybe it's me. I've had friends to where something has happened. I'm like, oh, I could not handle that. I don't think I could handle it or whatever. And then I've had friends of mine like, why are they having a problem with this? Why can't they cope with this? This is nothing. We don't judge. Everybody has their breaking point. So a family in crisis occurs when the family is not able to cope with some type of event. It could be whatever it is. Somebody loses their job, death in the family, somebody has left them, I'm all by myself. Whatever it is, that's something that you definitely, want to be aware of, and what it looks like when they've lost their ability to cope. So you want to remember that. It becomes, and how does it look like? It's disorganized, it's dysfunctional. Okay. They've lost their ability to be able to handle things. And it happens. It happens on an individual level. You'll see it in the hospital. You'll see it. It's not just the community, but this is community health. So that's what we're talking about. So when the demands of a situation exceeds their resources, as far as a family is concerned, they just cannot handle something. Okay. They're overwhelmed. Okay. They're overwhelmed with life. So you want to make sure, of course, that you get them to the resources they need, and be there for them. Genomes, if it helps to remember genes, what's in your genes, that is helpful as a nurse if you know somebody's genetics, so that you can, help recommend certain things. But that's what a genome is. It's actually, that's not actually what, this is an EcoMap picture. So the EcoMap is, I don't think I've ever had anybody do one on me, but just know what it looks like. Just know what a genome, how that would look. As far as EcoMap, if you look at that picture, let's just say in the middle, your patient is Alice. So Alice has Ralph and Kim, let's just say, as kids. And then Alice likes to go to church. Alice does this, Kim does that, Mary does this and that. Family interactions with the world. And so you do that more. You do that to show them. It's a visual, like some people are visual. It's one of many tools. And I know it's like a lot, like what is the genome? What is the EcoMap? There's so many tools available in nursing for whatever type of nursing you decide to do. Again, this is community health nursing to get the job done. It is not an intervention per se. You're just mapping out and showing them, okay, so, this is what's going on with your life here. You see, you're busy doing this, nothing wrong with being busy. See this, and then, you have to take Bill to his health clinic. And then, Bob's a freshman now, he's in athletics. So that's probably why you're stressed. It's just a visual representation of how the family, remember, that's the community you're dealing with, this family, how it looks on the map, so you can show them, and then you can see yourself. It's no wrong genome map or EcoMap. So then when you're looking at, like, again, the genomes, what is someone genetically predisposed to? It can give you the healthcare provider, that can give the public health nurse just the tools that they need to use for a person's unique genetic information. I have high blood pressure in my family. I have colon cancer in my family. These are things that some folks may or may not be aware of. So the more, knowledge is power. The more information you have to give to them, and vice versa, so they can help make the best health decision, so they can be as healthy as possible. Remember? So the information is designed to be the most effective treatment for that person. You're not going to decide, well, you know what, you need to get this done. You're going to present them with the genomes and the EcoMaps providing them information about the relationships that they have with their families and neighbors and everything. This is information for healthcare decisions that you can utilize. So that's what that is. And then what we do as public health, community health nurses is we're in homes, okay? It's just like a med-surg nurse going to a step-down unit to work a shift. Our shift is in the homes and in the communities. So you need to understand why home visits are the best type of assessments for what we do, okay? Because you want to go out to where you don't want to just be behind the desk and get all this data and birth certificates and age and race and never step foot in somebody's house and never actually see your community and how they live and where things are located and the services they have, and wow, it's this far to the clinic and that sort of thing. So therefore, you identify advantages and disadvantages as well. When you're going out to your home, it's just, you can pick up so much, not all negative as well, but you need to see what's going on in that community. You have to go out there. The assessment is interactive, meaning I'm asking questions. You want to make it don't seem like it's a laundry list. After a while of doing it, again, I don't need to take any paper in with me. I may take a pad out and write some notes, but you've been in positions to where when you start writing notes down, people look at like, what you writing? So then you got, I want to get into the nitpicky of it, but the point is that it is interactive. You let folks talk and then you ask appropriate question. Too much disclosure during the early contacts between the family and nurse may scare the family away. So it's delicate. That's why it's specialized. You just can't. When I started public health nursing, I was with a mentor for 6 months. I took a community health rep with me who spoke the native language, gave me street cred, if you will, before people would let me in their house without her. They didn't know who I was. So therefore it's delicate. So and it could be a slow process. You want to take your time and build trust, because you come into somebody's house. Like if you come to my house, knock on the door, I don't care who you say I don't know if I'm gonna let you in. Probably not. I'm gonna talk to you through the door first. Establish a relationship and a rapport before you do the assessment. So yeah, it's not where you go in the room, you do your head to toe, you leave your head to toe, can take a minute. And that's perfectly fine. So then I think also I wanted to touch a little bit about the health risk appraisal. We probably have done a health risk appraisal and you probably not have known, I don't want to say not have known it or really like it clicked. You're collecting information on lifestyles and risk. So this, if you've ever been given a form, maybe health insurance or what have you, where you're checking off boxes and they're going to use this information to look at your risks for a certain thing. So health risk appraisal is a process. So it's usually like a piece of paper, it's a checklist, and you can find them online too. It refers to the process of assessing for the presence of specific factors in each of the categories on that sheet. So for example, they're looking at someone's risk for a certain disease. They may ask certain questions about how someone goes about, like how many servings of vegetables they have per day. They're trying to try whatever the assessment is, and it can look like different things. They're looking at lifestyle and risk factors. So they're asking you a series of questions. They're going to put it all in a computer and say, okay, you're at risk for this. And I've seen them in insurance companies. Let's get you into the healthy lifestyle walking program, because based on this appraisal tool, you could be at risk for this. So then what is this? Secondary. Y'all left me hanging. Secondary. So this is an example of your secondary prevention. This health risk appraisal tool is a secondary action. So if you are a community health nurse and you're dealing with the health risk appraisal tool, it is secondary. Gathering information about the community, the person or whomever is filling out that form to design programs so you can reduce their risk and improve their quality of life. But the action is secondary. All right. Now let's talk about these kids. Infants, well, there are a lot of different age-related concerns, but we're really just going to focus on, for infants, you want to think about SID, sudden infant death syndrome. Back to sleep is what you're going to teach, but SIDS and abuse are two areas that they tend to be more vulnerable to. And then for children, what they want you to know is that environmental things. So I'm thinking like school age kids when you're doing an assessment as well. One of the things when you do, like if you do a windshield survey in the area, you're looking at, for example, I think they mentioned playgrounds. That's something that you can assess, looking at this. I don't want to say like inspecting the equipment, but just doing a general assessment, knowing what would put that child at risk. You want to prioritize your mentioned safety and recommendations as well. So then if children, I guess, when we're going to talk about school health nursing, so I don't want to get too far off this, but know that the environment is a huge area of concern for school-age children. And then adolescents, like motor vehicle-related injuries, not wearing seatbelts, motor vehicle injuries and violence are the leading cause or mortality for adolescents. So I think, so your teens, anyone can unfortunately die in a car accident. But I guess what they're trying to get you guys to focus on are just the top ones, like for infants, SIDS and abuse. For children, it's environmental related, could be exposures to lead, that sort of thing. But then adolescents, is car safety is important, and that's something I would remember. So for these adolescents, motor vehicle related injuries and violence, alcohol use is not alcohol use, I'm sorry. Car safety is the leading concern for public health at this point. So that's important to remember as well. And then risk assessment, getting into like the children again. Gun safety is another issue because, again, we want to make sure that if there are young children, and when I'm saying young children, I'm thinking of children that can get to a gun. I don't know how else to say it. So that's important. That's something that they want you guys to remember. So therefore, you're going to ask things about if there's a gun in the home, and you have to be delicate with people on their guns, but lock it. You don't want the school age child to get a hold of that sort of thing. Do they talk to the children about drugs and alcohol? Again, gun safety, you have to be just delicate. Again, that's not something you're going to ask from the first conversation because they barely let you in the door. But as far as young children is concerned, in the environment, gun issues is a huge concern for community health nurses as well. And then going into that school nurse, we talked about that in detail today in our class as well. He or she does, school nurse does so much. Injuries are the leading cause of death in children and teenagers. So you want to prevent. You want to treat, they treat emergency medical needs in school. They teach preventions. They work with reducing obesity and talk to teens about, smoking and what have you. So therefore, you want to know what that looks like for the school nurse if she was doing primary, if she was doing secondary, if she was doing tertiary. If she's teaching a class about fire safety, water safety, she's doing primary. If she's talking to the parents about screening their child for, I don't know, scoliosis, screening for something. If that word is used, is secondary. You know, tertiary would be when she's managing one of the children with juvenile diabetes or diabetes, and she's teaching them about how to give them insulin or what have you. So keep that in mind. I know we're at an hour, you guys. We are almost done. So then another, I love these old school pictures. This is actually a school nurse at an elementary school examining children, the children's eyes. Okay. And so this is in Philadelphia, 1910. And then again, so school nurses not only work directly with the children, she also works with the parents of the children. So then she can also teach the parents on a primary or a secondary or tertiary level, okay? And so she's working with the children, students, the staff, the family. She may teach different classes on how to cope with different health concerns that may be present in the school, so that they can continue the teaching and education at home to their children. These are things to be aware of. And then, so primary prevention, again, I know if you go in knowing this from the beginning, you're going to do so good in community health. Primary prevention, what are they at risk for? We're going to give them a flu shot so they won't be at risk for getting the flu. We're going to do educations. We're going to do vaccinations. We can do programs and educational programs to teach parents or children or whomever about reducing the risk for this, improve how to cope with different issues at school. It can look like various things, but it's still primary. If she has a program together, if she puts together some kind of educational class, if she's giving them vaccines, no disease exists. Maybe they're at risk, maybe they're not. But again, primary, there's nothing, there's no disease there, period. If it doesn't talk about a disease, it's not primary. I mean, if no disease is there, it's not primary. I know it's getting late. So then your secondary, your screenings, your surveys, your surveillance, if we do find a condition is asymptomatic, let's just say, and I'm trying to just keep this really black and white, you don't know it when you're doing that screening. That's why you hear the terms early detection for a cure, early detect this, but the action you're doing is secondary. So today in our video for the folks in my class, one of the things I said, pick out something secondary. When the nurse sat down and was checking the kid for head lice, she was screening for head lice. So she was doing a screening. Primary would be if she, beginning of the school year, when she has a meeting at the PTO and talks to the parents about head lice and how to prevent it. But then if you sit down and your action is actually checking for head lice, that's screening, okay? And then tertiary, anything you do after you know that someone has a condition is tertiary, all day, every day, that ends in Y, okay? That means somehow we've let primary, secondary get passed, and now folks have high blood pressure. Now they have diabetes, and now they have these conditions, and we just got to deal with it and make sure that folks, you know, live as long as they can. All right, I literally have 2 more slides. So ethics. Ethics is something you need to understand about yourself before you go into nursing, okay? Because as a nurse, you're going to come up with these challenges and situations that's going to try you, and you need to know personally inside yourself where you stand. So if a nurse, chances are you have faced situations, or you're going to face situations where you have to make these decisions based on what you believe, or whether something is right or wrong, safe or unsafe. I have folks that I work with, they're called, well, the term is conscientious objectives. Don't have to memorize it, but they won't give plan B. They won't give out plan B or Ella. And we already know that. So then as a provider, I give out plan B or Ella. That's not an ethical issue for me, but from some nurse practitioners I work with, it is. I get it. Okay. So this type of decision is based upon your ethical behavior, your system, your values, deals with moral dilemmas. And then, so then your Nurse Practice Act, for every state, there's a Nurse Practice Act on what you can and cannot do as an LPN, as an RN, as a nurse practitioner. It protects the public from, I don't want to say from us, certain states will allow you to do this. Just know whatever state you're going to practice, you want to know what your Nurse Practice Act is. You know, I'll have someone ask me to do something, a new supervisor. I'm like, and that's not in my scope of practice. You'll hear that being said. So just know that you want to keep your license legal. We've heard of nurses that have lost their license for doing this, that, the other. Okay. You're resilient, you're bent, but not broken. And then I am going to, and let me just wrap this up. I'm not leaving. So that concludes our exam 1 presentation review for July 21st. Thank you and good luck on your exam.
Thank you.
Thank you, guys. Thank you, thank you, thank you. I am trying to figure out how to, there we go.